Sachin, make it live. Make it live to the audience. I'm taking off from here, ma'am, and leaving the meeting to all of you. And I'm seeing from the participant side, and we are checking with the YouTube and other social media channels also. So,
okay, thank you, Ashish.
all the best. All the best, ma'am. Over to you and Ravi Kumar sir and Dr. Harbans. Taking your leave. Sachin, make it live to the audience, please.
Ma'am, we are live.
Yeah.
Welcome everybody once again, and this is the second masterclass in this series. The first masterclass that you had was from the North Zone, and this is the AIOS masterclass on cataract surgery from our southern part of the country. So we have with us Chairperson Dr. Lalit Verma, President All India Ophthalmological Society, Director Retina Services, Center for Sight, New Delhi. Dr. Harbans Lal, who's the President-elect Director, Delhi Eye Center, and also the co-chair, Department of Ophthalmology, Sir Gangaram Hospital, New Delhi. Then we have moderators, Dr. K. Ravi Kumar Reddy, Medical Director, Medivision Eye Care Center, Hyderabad, and Dr. Rajesh Sinha, Honorary Treasurer, All India Ophthalmological Society, Professor of Ophthalmology, Cornea, Cataract, and Refractive Surgery Services, RP Center, AIMS, New Delhi. We have a galaxy of speakers with us from the south. Dr. C.V. Gopal Raju, the Managing Director, Vishakha Eye Hospital, Vishakhapatnam, who will be talking to us about phaco and floppy iris. Then Dr. Sri Lakshmi Nimagada, Managing Director, Win Vision Eye Hospital from Hyderabad, who will be again dealing with a very important aspect, post-cataract patient care, inflammation, dry eye perspective. Dr. O. Gopalakrishna, Medical Director, Modern Group of Eye Hospitals from Nellore, who would be talking to us about primary posterior capsular deficiency, tips and tricks. And Dr. Narayan Shetty, Vice Chair, Narayan Netralaya, Bangalore, who's going to be talking to us about biomarkers to customize treatment. So we would begin the session now. And before we begin, I would request the President-elect, Dr. Harbans Lal, who's with us to say a few words, because before we finally commence the session.
Thank you, everybody. Thank you, Alargan, for organizing this. And I see very exciting program. And I think let's start straight away, go to the scientific program and meeting.
Thank you so much, sir. Now I would request Dr. C.V. Gopal Raju, who is the first speaker, to talk about floppy iris syndrome.
Can you see my slides?
Yes.
Yeah. Can you hear me?
Yes.
Yeah. Thank you. Thank you very much. Thank you, Dr. Namrata, and then Dr. Harbans Lal, sir. And also thank Alargan for organizing this meeting. Today, I'll be speaking on the intraoperative floppy iris syndrome and associated with the alpha blockers. No financial interest disclosures to make. So, floppy iris syndrome was in the sense when we started the phacoemulsification, that time it was not recognized or described. So way back in 2006, when we were operating, this is the kind of a situation we used to face. If you see, the iris started coming out of the wounds, and also when we are doing the phaco, there was a tremulousness of the iris. Then in this case, you can see the iris floppy, and then the pupil is gradually coming down as the surgery progresses. And the moment you come out and then inject any viscoelastic, the first thing to come out is the iris. So this is the situation. At that time, we were not aware about this situation, and then we were thinking why it is happening and all. Then this is another case where the iris, initially when we started, this case was started, the pupil was nicely dilated, and we were not aware about this, the alpha blockers, and then the prostatic problem using this drug. So we were not at all asking the patients about this. And this has all become an intraoperative surprise. The main difficulty here is the first thing to come into the phaco wound is the iris rather than any other structure. You can see how the iris was damaged here. So somehow, luckily, I could escape without much damage in this case. Then we went back to the literature and we have seen why it is happening. And then it was described way back in 2005. And they also noticed a strong association between the Flomex. Flomex, it was the first introduced drug, that is tamsulosin, and then the benign prostatic hypertrophy and the floppy iris syndrome. It is not only limited to the BPH and then the Flomex. It can happen even in the females, and when they are using the alpha blockers for the antihypertensives. And even without that, all the ocular conditions where there is a chronic small pupil and then atrophic iris, like pseudoexfoliation, chronic pilocarpine therapy can also have this kind of a floppy iris syndrome. And it is already proved that the surgical complication rate is higher in the floppy iris. So then we went back to the basics. The iris anatomy, you all know the dilator muscle and then the sphincter pupillae. Dilator muscle is innervated by the sympathetic system. And then where the sympathetic system acts through a receptors. This is the alpha-1 receptor, the alpha receptors. These alpha receptors are again classified into alpha-1 and then alpha-2. So whereas our interest is mainly in the alpha-1, alpha-2 is the presynaptic nerve endings it acts, whereas in alpha-1, it is situated in the dilator muscle. In addition to the dilator muscle, the same smooth muscle alpha receptors are also situated in the pylorus of the duodenum and also the prostatic and then the smooth muscles around the ureter. So actually, we are the unfortunate victims of the somebody else therapy. When they are treating the urinary problem, we were the victims for that. So it's our responsibility now to educate them. So again, in the alpha, there are two types, alpha 1A and then alpha 1B. So alpha 1A is the subtypes. So they acts on the muscle, whereas alpha 1B acts on the vascular system. So why it is important means there are drugs, they classified the alpha adrenergic blockers into a non-selective and selective blockers. Again, in the selective category, there are alpha 1, alpha 2, and then in the alpha 1, again, alpha 1A and alpha 1B. There are subtypes are there. So the drug which is more acting against the alpha 1B, which is situated in the muscle, is the most the culprit. So tamsulosin, why there is a strong association is the tamsulosin is the drug which directly acts on the alpha 1A. So to summarize this alpha receptor blocking agents, alpha 1A, the adrenergic receptors mediates iris dilator, smooth muscle and contraction. Alpha 1B mediates the iris anterior contraction. So alpha 2 acts at the presynaptic level, so which may not be of much influence on us. So their drugs are again selective blockers like alpha 1 and alpha 2, and subtypes is alpha 1A. So finally, just remember about the alpha 1 and then alpha 1A. So this is the main the drug, whichever drug acts on this agent, on this receptor, will be worst affected. So these are the top types. So tamsulosin is mainly acts on alpha 1A. The other drugs, nowadays there are many drugs the urologists are using, like the terazosin and then doxazosin, then aflorozin. But the most the dangerous drugs for the ocular point of view is the tamsulosin and aflorozin. These two are the drugs. The main advantage of these drugs for the urologist point of view is they act mainly on the smooth muscle. without much effect on the systemic postural hypotension. So that is the reason why the side effects are less and they get the maximum effect on their point of interest. So that is the reason why they were using that. But unfortunately, these are the two drugs will have a maximum effect on the dilator muscle. And when we search this literature, what is the current pattern of their treatment in the systemic point of view? Urologists, they like an alpha blockers. They're become a first choice of treatment in the benign prostatic hyperplasia. Even in the women with the hypertension, also some of the physicians preferring the alpha blockers. And if there is a combination of the BPH and then the hypertension, some of the physicians are choosing the alpha blockers. And there is also not only is limited to the males, in the females urinary tract symptoms also, there are studies which they are using the alpha blockers. So finally, I can say in future, this is become inevitable, we cannot avoid this, and the numbers are bound to go into increase. Coming to the clinical effects, how can we recognize this? Yes, we can recognize in the preoperatively when we are very sensitive about this. What people, size of the people is the best indicator whether the drug has already have an effect on the dilator muscle or not. If the pupil is purely dilated only on the alpha blocker, definitely we can say this case is going to have a difficulty during the surgery. And during the surgery, the iris billowing and then prolapse and progressive intraoperative meiosis is an indication. And the worst thing is already who are using on that, especially tamsulosin, 90% of those patients will definitely have some form of an IFIS. And the worse than that is even if you discontinue the drug, still that effect is going to last. And even if they have used it several years back also, still we will have an IFIS. So now coming to the strategy. So we cannot avoid this. Coming to our strategy is we should include this in our preoperative checklist. And then in the clinical examination also, we should anticipate, plan, and then prepare the patient accordingly. Then it is no more a routine surgery. We have to prepare the patient under the visual prognosis. When it comes to the surgical steps, the wound construction should be of more corneal. The tunnel length should be more so that the iris will not come out very easily. And we should try to complete the surgery with a smaller wound with one entry instead of going frequently into the AC and then coming out. And then during the chamber, try to stay away from the iris. And then we can use a pharmacological agents like tropicamide, phenylephrine, lignocaine combinations nowadays are intracamerally available. We can use that. In a moderate cases, we can get away with that. In worst cases, the best thing is to use a pupil expander. Let me show some of the cases. This is the combination drug which I generally use. Here, in this case, the pupil was reasonably dilated with a history of the alpha blocker usage. We should use intracamerally the combination drugs of the dilators. And then if you see, even in spite of that, the people, by the time we are reaching that, it's almost coming down. So with the pharmacological agents, you can see the floppiness of the iris. Now you can see how the iris is fluttering. So pharmacologically, in a moderate or a mild cases, we can complete. Coming to the another case, this case is again a small pupil with the with the effect of the alpha blocker, but here the nucleus is very hard. In these cases, we can try with our earlier strategies like staying in the center, avoiding long tunnel, and keeping the chamber deep. With the pharmacological agents, we can complete the surgery successfully sometimes, but one should not hesitate to using the pupil expanders. Coming to this case, so we can see definitely the pupil is on a lower side. So one should not hesitate to use the rings, expanders. Again, coming to the expanders and then the retractors, in this case, expanders will be a better choice. Coming to the expanders, I would prefer a slightly bulkier a Gupta ring or the ring than the BHEX. BHEX is little delicate, and then the pupillary dilatation also. Here the main idea is we should stretch and keep the pupil try to be away, and then keep the diaphragms still lower than the wound level. So in this case, a expander like this will be a better choice, and then we can complete it successfully with that. Then at the end, you can see how the pupil was lax. I could complete it, and in spite of the very small pupil. So pupil expander is a better choice. So to summarize, we will see more and more of these kind of cases in future. Preoperative planning, including the checklist regarding the usage of drugs, clinical examination, and then keeping them on a guarded prognosis, like wound, whatever we discussed, the wound architecture change, and then our maneuvers, and then other things. The another most important thing is we should start educating the urologist about this problem, and then that is the only way I think in future. Thank you very much.
Thank you so much, Dr. Gopal Raju, for that wonderful and a very complete lecture. This is open for discussion. Dr. Harbanslal sir, or any of the
So I will just like to make one comment. I think pupil expanders are excellent, but many times the iris starts prolapsing from the side wound or for the main wound. In those cases, of course, we need to do hypovolumic phacoemulsification. Besides that, people should also know how to put the iris hooks. And aim of the iris hook is that the pupil border should go beyond the entry point of the incision. That means wherever is your internal wound, if you can pull the pupillary border beyond that, that means towards the periphery, then it won't prolapse. And so when there is a very little left, or you don't have the rings, and many times rings may not work and hooks may work better in certain situations. So people should also be aware of how to use the hooks.
Yes, sir, I agree.
Shall I add a point, sir? Along with the drugs which you mentioned, there is a whole list of generally routinely used antihypertensive, anti-diabetes, and antipsychotic drugs. The whole list of medicines are there which can cause this floppy iris syndrome. The entire list is given was the textbook and the FAP difficult situation. A whole tabular form is there. At least commonly used drugs like antihypertensives, anti-diabetics, and all the psychotropic drugs, they're all involved with the floppy iris syndrome, sir.
Yes, yes.
Dr. Narayan, you wanted to say something?
Thank you, ma'am. I think sir has wonderfully covered the topic, and he told a very important point on educating the urologist. Fantastic, sir. I would like to add one more point on the viscoelastic, which sir also mentioned, is viscoadaptive, like Heal 5 or something like that. I have no financial interest, but using in these kind of situations, it makes the situation a little more easier to handle. If you don't have viscoadaptive with you, you can also use like a viscoat. What you can do is just inject a little amount of viscoat at the ports, the different ports, the side ports and the main ports, so that it holds the iris back. Then you fill the chamber with whichever viscoelastic which you're comfortable with. So that way it will push the iris away from the ports when you're trying to enter. These are just some few tips which...
Yes, yes.
So, Dr. Ravi Kumar Reddy, sir? Yes.
Yeah. So the important thing is when you make side ports, anterior and long side ports, but there should not be any disproportionate between the size of the port and the instrument you are using. Say, for example, you are using chopper. The chopper size and the side port should be same. If at all there is a disproportion, you can use two side ports in the same side, one for the chopper, one for the IA. For chopper, it should be a very, very fine side entry where there is no leak, no prolapse of the iris. This point of Naren is well taken. I also do that. Whenever there is a repeated prolapse, we inject from side port viscode to the main port, underneath the main, so that it will fall down and you can retract the thing. And we use regularly BX ring, no problem in using BX ring, even though it is a delicate.
Yes.
I think very useful points. If you try to put Helon, it comes out and the iris will come out with it. But if you put viscode, it sits back and goes down. Very important.
And also using low parameters, always, slow motion frequency.
I think sir said that hypovolemic frequency. Sir, we'll move to the next talk.
Yes.
So the next talk is going to be by Dr. Sri Lakshmi Nimagada, who she's going to be talking about post-cataract patient care, inflammation, and dry eye perspective.
Start sharing the screen. Okay. Skip that. Can you see my slides now? Oh, yeah. Thank you so much for the opportunity. Thanks AOS and Dr. Namrata for giving the opportunity, and it's feeling very happy and privileged to share with the platform with eminent doctors over here and my beloved teacher, Dr. Ravikumar Reddy sir. So my topic is on post-cataract patient care, inflammation and dry eye perspective. That means we have to make the dissatisfied, unhappy patients happy. So over the years, we have come to this far in cataract surgery, from right from the amazing microscopes and pre-operative diagnostics and intra-op diagnostics, which only to reinforce or improve the visual outcomes with outstanding fluidic machines, femtosecond lasers, and excellent IOL designs. And also the parallelly developed is the pharmacological innovations. So whatever is the form of cataract surgery, eventually you are going to have inflammatory response. So if you don't control the inflammation, end results will be in the form of poor visual outcomes. You can have delayed cystoid macular edemas, raised intraocular pressures, and corneal edemas, all these things. So the response has to be controlled either by using topical steroids concomitantly with the non-steroidal anti-inflammatory drugs. So I'm going to discuss about 3 scenarios here for the inflammation part. You all must have encountered toxic anti-segment syndrome, known as TARS. Although it is rare, but is as devastating as endophthalmitis because of its presentation. Until you get your gram-negative stains, cultures come negative, you get worried. And fortunately, it responds to the steroid medication. So once you encounter this situation, you need to have a complete analysis of your fluids, your instrumentation, everything to be reviewed, sent for the labs, and then also complete analysis, review of your OR and your sterilization methods. So, and this particular inflammatory thing, when it responds to steroids, but you need to be watchful of the endothelial cell toxicity. So you need to perform the specular microscope once the patient back after 3 months or 4 months, you need to do the specular cell count. So another scenario is the rebound iritis, which is pretty common. And the moment you taper the steroids, the patient comes back to you with back to the redness, pain symptoms, and they'll be worried, doctor, what happened to my eye? It's again, the moment I stopped the medication. So in this, the risk factors, these recurrent uveitis with some autoimmune connective tissue disorders, So there, the patient also understands and that, been going through these recurrent episodes. So it is easy to handle these kind of scenarios, and you have a strategy here that you start your steroid medication as a preoperative cover, and also never ever do on a inflammatory eye. It has to be a quiet eye with a strategy of pre-op steroid cover. And other things, as already Dr. Gopala just very elaborately spoke about the floppy iris or, rigid pupil scenarios. And then, so in this, you are manipulating the iris so much, you want to get this rebound iritis. So sometimes, we see that we can get away from the not using the expanders. I'm more comfortable with the retractors than the ring. So I usually do this, but sometimes, it can get away. So you see there so much of manipulation, your iris starts prolapsing. You can't, your pupil, once it gets constricted, you don't see, you're unable to remove the nucleus entirely, and you miss out some cortex as well. And this much of, manipulation, you bound to get rebound iritis. And another scenario, see, once you miss this, you may see some fragment in the anti-chamber if you examine in the next day. And then sometimes cortex, which is missed out, probably unapproachable when the pupil gets constricted, or sometimes subincisional, it's pretty tough to remove. Then this cortex also will dissolve slowly, and you keep on getting these inflammations recurrently. And another scenario is where, you think you implanted the lens in the back, but one haptic might have sitting in the sulcus, which constantly rubbing the iris. And also, you should never keep the acrylic hydrophobic in the sulcus. So if there is any posterior capsule rupture, so always 3-piece is the best to implant in the sulcus. So once you deal with these kind of, scenarios, but then even then, regardless of that, sometimes you see this rebound iritis. So the strategy should be tapering from the stronger steroid to the weaker steroid will work better along with cyclophysics. It definitely works better. So this particular case, I just want to show you this. After doing a beautiful surgery, I implanted this lens, and the both optics got stuck to each other. And so how much ever I tried, I couldn't separate them. So I left it, and when next day patient comes with hyphema, and then, all these raised intraocular pressures. So eventually I did a AC wash and intensified the steroid medication. So here the loading was the problem. The loading did not happen well. So everything is essential. So need to understand the loading of these lenses. It's not the lens fault. And another scenario is this cystoid macular edema. Primarily, this rebound iritis is the extension of this cystoid macular edema is the extension of this rebound iritis. So apart from the, the risk factors, I'm showing one case which has a very hard rigid pupil and then hard cataract. These cases, all the complications may happen, jugular dehiscence or posterior capsular rupture, and then vitreous loss. So instead of, meddling like that, best thing is to do a straightforward SACS, but only thing was there was no nuclear drop, of course. All these things will lead to the cystoid macular edema. And apart from this kind of scenario, we have risk factors like diabetes, vein occlusions, either it's in branch vein or central retinal vein occlusions, and ERM. ERM has the tendency to develop these cystoid macular edema. So Not that patient will have, from the grade 1 or grade 2, may not be having the visual symptoms, but you need to choose your lens carefully. Cannot put a multifocal because of it's prone for cystoid macular edemas. And also prostaglandin analogs for the AGMs need to be watchful. And of course, the incidence has been reduced. Primarily your cataract surgeries out with the great phaco machines, and your surgical excellence has been increased, not seeing much, and also because of the NSIDs, it's such a boon. So coming to the diagnosis of cystoid macular edema, sometimes it is may not be visible on clinical examination, but it can be picked up on the OCT, which is a non-invasive manner. And you can typically see the petalloid pattern on FFA. So coming to the management, so NSAIDs are the mainstay of therapy. And in steroids, when the topical and NSAIDs are not helping, you can give a PST. So intravitreal triamcinolone, you need to be watchful for the increased intraocular pressure. So now we have anti-VEGFs, which are really helping in recurrent cystoid macular edemas, especially patients who are diabetic. You see such kind of along with the diabetic macular edema. So they are very helpful. Another condition is retinitis pigmentosa. In our Telugu states, it's pretty common because the marriages happen in the consanguinity. So most of the kids will have this RP, and when they come for the cataract, you need to be very careful, because don't write it off that they already have constricted fields, anyway, compromised vision. They may be having pre-existing CME, or they may develop CMEs post-cataract. So you need to have a close monitoring of that. And coming to the surgical management, sometimes, it may form VMTs. You have to have a pars plana vitrectomy depending on the situation. And coming to this, yes, there is more to this than meets the eye. The most appears simple, but it's more complicated. Because, cataract patient, as a refractive surgeon, we counsel so much these youngsters when they approach for the laser vision correction. I tell them to, how important the artificial tears to be used post laser vision corrections. But never I really talk about this to my cataract patients. Mostly, talk about the how the procedure can be done, like use flags or MICS, and about the IOLs, what type of IOLs and all that. But probably because laser vision, it's an option. They can do any kind of thing, or they may end up with glasses. But if it is cataract, it is a compulsion. There is no other choice for them. Maybe we take it for a ride. We don't talk about too much about dry eye. So that's the reason that is being very underestimated, and the patient comes back to you cribbing about the foreign body sensation, stinging, or some kind of nagging pain all the time. Then we get alert and try to counsel them. But if you do that preoperatively, giving more chair time, like your refractive surgery patients probably, because cataract also is a refractive surgery. So what will happen in cataract surgery, the tear film instability because of the increased inflammatory cytokines, and they're already pre-existing meibomian gland dysfunction, which will be more aggravated. Because nowadays, it's all corneal, clear corneal incisions, so the nerve endings will be severed, more corneal sensitivity, reduced corneal sensitivity. And on top of it, using the topical drops will make so much of, SPKs and epithelium become more frail and fragile. So if you see this vicious circle theory, so the ocular surgery inducing the cytokine releases and MMP activation, which in turn there will be goblet cell loss. There will be tear film instability caused by this, and then hyposecretion. Then the pH has changed and hyperosmolality to cell apoptosis and delta. This is the cycle. Apart from the patients having a pre-existing connective tissue disorders, or of already laser surgery done. Probably the laser vision, the LASIK done patients are the most, easy to handle. They have already went through this dry eye treatment, but others, they crib a lot. And also we see so many antidepressants, people who've been on the antipsychotic drugs also will have these dry eye scenarios pre-existing. And we see so many times the conjunctival calluses, we always, try to pump them with lubricants, but still it is like a watershed, but we give them lubricants, artificial tears. That's very tough to treat. I don't know, I have to ask the panel about the congenital calluses, how to treat that. Because they be the most unhappy and dissatisfied patients who have these conjunctival folds. And there are questionnaires designed by this Ocular Surface Disease Index by Allergan and IDEAL from Alcan, like impact of dry eye on everyday life, like McMoney's dry index. So this gives a kind of score so that you can decide whether patient is having no dry eye or minimal or moderate to severe. So if it is moderate to severe, maybe you need to delay the cataract surgery and plan it later by treating them. And also diagnostic tests primarily to differentiate the aqueous deficiency or there is a hyper evaporative status. So honestly, I don't do all this, but I think this is the need of the hour. We need to perform so that to make these dry eye situation to a pristine ocular surface. So what are the preoperative recommendations? We're not supposed to avoid this, preservative drugs. So we have now, but we are bound to use moxifloxacin, which is really epithelial toxic, although they say Vigamox is preservative free. But still we see that epithelial toxicity happening. And when coming to the, powder-iodine drops as a prophylaxis for end off, I would rather prefer, treat dry eye than, not to end up. So we probably the powder-iodine or other topical drops should be manufacturers think of using with the preservative free. And now we are also, picky about target emetropia. So we don't want our patients to have any kind of astigmatism. If it is not a toric IOL, we try to use arcade incision or LRIs or opposite clear corneal incision, which is much, very cheap and you can minimal astigmatism up to 1 cylinder, you can treat them. So, and also because when their intense topical drops are being used, the epithelium become very toxic and little manipulation, sometimes you create the epithelial defects. So all these leading to the aggravating the dry eye situation. And post-operative, what we have to do is treating them with artificial tears, that too with the preservative free. And NSAID is again, I believe in, I'd rather treat dry eye rather than, ending up in inflammation. So I think there are a couple of Nepfinac preparations which are preservative free. I think Amplinoc is that, but not every Nepfinac is preservative free, of course. And when the patient is preferring the premium IOL, it is, even if not is a premium IOL, these IOL calculations mainly depend on your corneal pristine ocular surface. So it will disturb the outcomes as well. So treating them at least for a couple of weeks before planning the surgery, if you see any meibomian gland dysfunction or blepharitis, better to treat the patients first and then send them for the biometry. So coming to the treatment strategies like tear film instability. So there are artificial tear supplements and preparation to tear retention. And if there is a hyperosmolality, osmoprotectors are available. And I don't know about omega-3 fatty acids. I don't see much of them. There are studies supporting it, but there are studies also not very truly helpful. And coming to the immunomodulators, sometimes they are like restasis. It may be helpful for the when there is inflammation also concomitantly will help. And stabilization of lipid layer is the mainstay for the meibomian gland dysfunction. So these are the treatment strategies available. So to conclude, it is no longer considered just vision restoration. Now it is a kind of refractive surgery. So strict vigilance on inflammation with mandatory dry eye management protocol should be the standard of care. So that's how we can translate these dissatisfied patients as happy patients. Thank you.
Thank you, Dr. Sri Lakshmi. I think you did the most difficult talk. To have a dissatisfied patient after cataract surgery and then to tackle it and find solutions thereof is, I think, the most difficult part. Easiest thing is to do surgery.
Yeah.
So this is open for discussion, and I would like to bring to everybody's attention an advisory which had been given by the ASCRS just yesterday, day before yesterday, that you should use moxifloxacin intracamerally with caution, because the dose is 500 micrograms, whether you use 0.5%, which should be 0.1 ml, which should be used, or you use 0.1%, which should be 0.5 ml, which should be used. Because if you don't use the correct dose, then this can lead to TAS, toxic anterior segment syndrome. So, sir, you would like to say something about the
I think chronic inflammation, I had two patients. One was done flax somewhere else. And once we are going for DSEC, then we realized there was a fragment which was underneath the iris at the sulcus. And patient after 1.5 years developed corneal decomposition. So I had another patient of my own who was one-eyed, and after 2 months, his inflammation continued, and suddenly I noticed that the pupil was getting pulled onto the one side for no rhyme and reason. So if you ever find there's uneventful surgery, the pupil should have been round and white is getting pulled. And then we went and explored, we found that a small fragment was underneath the iris. So in a chronic inflammation, particularly high myopes, and in a very prolonged surgery, when the very hard cataract, you really start getting tired, and these hard fragments actually roam around much more than the softer nucleus. So when you're operating a hard cataract, inflammation is not settling down, and if the pupil is becoming irregular, which was normal, so probably there may be a nuclear fragment lying underneath the iris.
So I think very well said, sir. And Dr. Sri Lakshmi also showed a similar case in her presentation. Besides this, there are a few questions.
No, that was Namrata in front of the iris, which you can see on the slit lamp.
Otherwise,
I'm talking behind the iris, which you will even miss on a UBM many a time. So, and it's very difficult to think why the inflammation is taking place when everything looks normal, all right. So if you find any pupil is becoming irregular and inflammation is not settling down, and previously if the patient had no uveitis, nothing, and particularly the cataract was hard and high myopes because the chamber is very deep. So there are certain cases which are prone to going a fragment behind the iris and in front of the capsule. And they are very difficult to remove if you know.
There is a question from Dr. Amanpreet Singh from the previous talk on how much time patients should have temozolocin in the past to land up into IFIS. For what period of time is there? Are there any studies? And I think the second question of his has already been answered. Will stopping temozolocin 1 week before have any effect on IFIS?
And there are studies saying that even a single dose of tamsutin will cause some amount of damage, ma'am. So there is no point in stopping medication also. There is not much of use.
But the only thing we can say, the longer the usage, the more will be the effect.
Yeah, that's always there.
Actually, I think latest David Chang lecture in AO was that probably if you stop 1 week before, it may decrease the AFIS. But really, I think you got to go prepared. I mean, very simple, and the best already, most of the strategies have been already defined. And hypovolumic is one thing which should be really minimum fluid disturbance, or minimum manipulation in the anterior chamber, minimum fluctuation will help it keep it there.
Then there's another question. Any benefit of using intracameral alpha agonist in IFIS? I don't think anybody has used, but if anybody knows about it, no. So that is not there. And then there is a question, are SOC containing eye drops completely safe? I don't know what SOC means. So povidone iodine drop can be diluted to reduce the epithelial haze. So I don't think we can dilute it to reduce the epithelial haze. But yes, the latest advisory I wanted to bring to everybody's attention that moxiflox, if not used in appropriate concentration and appropriate volume, can lead to TAS. So one has to be careful about it as per the ASCR's advisory day before yesterday. Any other comment or any other question? I think we've lost Dr. Ravi Kumar Reddy.
Intracameral, when we are using the cocktail of those three, so phenylephrine is one kind of a
Alpha agonist, yeah.
stimulator, alpha agonist.
Okay, so we have, we can move to the next talk, sir.
Yes, yes.
So with this, we move to the next talk, and the third talk is by Dr. Gopalakrishna.
Yes, sir. Yes, ma'am.
So another very interesting talk, and the topic is primary posterior capsular deficiency tips and tricks.
1 minute, ma'am. I'm just trying to share.
Meanwhile, Dr. Ravi Kumar Reddy, sir, would you want to
Yes.
comment on Dr. Sri Lakshmi's talk? I think which was a very tough call.
Yeah, it is a most she has done her job nicely, because this is a most difficult job, and the well taken point is most of the time we miss some cortex or the fragments which we miss. That is the commonest. As far as the toss is concerned, when you dispose the what are the things like cannulas as much as possible, the possibility of toss is much less. And also rely on the standard drugs, especially BSS and the Visco. If some representatives come, this is a new one, this is the best one, this is the cheapest one, means you land in toss.
Ma'am, can you go ahead with the second talk, ma'am? I'll just come back in a few minutes.
Okay, so
Yeah.
we go with the next talk. Dr. Naren, are you ready with your talk? I think Dr. Naren Shetty is not there online. So we'll have to go with yours only, Dr. Gopalakrishna.
I'll take 1 minute, ma'am. Just give me 1 minute, please.
So meanwhile, I think even the topic of dry eye post-cataract surgery is very difficult to tackle. Sir, Dr. Banslal sir, would you like to comment on post-dry eye cataract?
I think before doing surgery, patient is having really severe dry eye, or if there's a lot of meboritis, I think we should delay the surgery by 2 to 3 weeks and treat them beforehand. Then it becomes very easy, because post-operatively patients are very reluctant to do any type of massage or any type of hot formulation, and then you are putting so many medication. And but at the same time, after 3 days, you should stop as many medications as possible. I mean, stop the antibiotic after 48 hours to 72 hours, stop the anti-inflammatory, because they can also cause the dry eye, and stop if you're giving any anti-glaucoma medication, stop all those. So then only thing should be left should be the steroids and the lubricant eye drops. So I think the minimum medication, and which I think most of the time we over medicate. Most of the time we write 5-7 drops which patient is using. So after 3 days, I think you can really stop all other medications.
Naren, can we take your talk? Because
Sure, ma'am. Sure. Can I share my screen, ma'am?
so Dr. Naren is going to talk about biomarkers to customize treatment. I think again a new topic completely as far as the cataract surgery is concerned.
Yeah.
Yes, Naren.
Yeah, thank you so much, ma'am. On this onset, I would like to thank AOS and Allergan for giving me this opportunity. So now we are in the era where there's a lot of misuse of drugs, because of which there's a lot of multi-resistant organisms in the world, And in fact, if you look at the stats in 2050, there's going to be a big jump in the number of deaths which can happen because of these multi-resistant organisms. So customized treatment or personalized medicine is extremely important in this from now onwards. So how do we do this? So let's play a scenario where I'm sure each one of us have had cases where post-surgery, you see these reactions in the eyes, and during the early stage, you keep wondering whether this is a sterile one, is it infective? If it is an infective one, is it a bacterial, viral, or fungal? Some of us think, some of us be very aggressive in the treatment, or some of us think, okay, let's wait and watch and see what happens. Then eventually you get a picture like this, and you immediately rush the patient to the OT, do a very invasive AC tap or vitreous tap, and send all this to the lab. This is a very invasive, very inconvenient for the patient, and also it's very, it is expensive, and also it takes time for the report to come back to you. And in these scenarios, a missed or a delayed diagnosis can lead to blindness or loss of ocular architecture, and early detection is the key in such scenarios. So the research question is, can we do a non-invasive, quick, simpler, affordable test? And we found something very novel. We call this the TED. TED referring to tear endophthalmitis autoimmune detector. So the aim of the study was to do a tear endophthalmitis detector of infective etiology and its correlation with conventional microbiological testing. So these were the objectives, is to study the tear profile and correlate with endophthalmitis, to study the microbiological profile using standard lab tests, comparison of the results with microbiological diagnostic methods, and also study the correlation with tear profile using metabolomic profiling. So this was the inclusion-exclusion criteria. We excluded any kind of a lid abnormality. This is how the methodology looked at. We did a detailed ocular and systemic examination. Sample was collected of the tears, aqueous, and the vitreous, and different analysis was done. Basically, we did the gram stain culture, PCR, and UPLC mass spec. This is how the sample preparation was done. I won't go into too much detail because of the shortage of time. And this is how the data was analyzed. So the expected outcome was quantification and identification of metabolic regulators, and also identification of key metabolic pathways. So here you can see differentially expressed metabolites in bacterial endophthalmitis. And here you can see a supervised cluster showing a distinct separation pattern between bacterial and control group. Here you can see a heat map showing major differences in expression in metabolites in control and bacterial endophthalmitis cases. So this is the list of altered metabolites. We had similarly, we found something very unique: altered metabolites in viral endophthalmitis and fungal endophthalmitis. So what was already known was diagnosis of endophthalmitis is based on clinical examination supported by microbiological investigation. What this study adds is an altered metabolic pathway in tears in endophthalmitic cases correlate with those found in aqueous and vitreous. And tear metabolic profiling may be able to identify endophthalmitis, may serve as an early diagnostic modality, obviating the need for invasive testing. So how do we use this in our clinics? So basically, we are developing this diagnostic kit with which just by, let's say if you suspect some kind of infection in the eye post-cataract surgery, and you can collect the tears with these Schirmer strips, put it in this diagnostic kit, which is going to be very affordable, portable, and you can keep it in your own clinic. And within 30 minutes to 1 hour, you get the results in your hand, and that way you can start the treatment very early. And obviously in these kind of scenarios, earlier the treatment, the better the results, and patient sometimes you won't know that something went wrong. So let's look at which other scenarios can we use biomarkers in terms of treatment. I'm sure each one of us have had cases like this where before surgery itself, patients had some kind of retinal pathology. And not all the cases, but some of these cases worsen post-cataract surgery. So the research question was, can we predict before surgery which patients can have worsening of retinal pathology post-cataract surgery? So we did a prospective interventional case study wherein we did the follow-ups at 1 month, 3 months, 6 months, and 1 year. And these were the inclusion exclusion criteria. And it was we divided into 2 groups. First, based on systemic illness, where group 1 had only diabetes, group 2 had only hypertension, group 3 had both hypertension and diabetes. And the next group was based on whether there was presence or absence of retinal pathology. So if you look at the results, there was a significant increase in VEGF and MCP1 in patients group which had both the diabetes and hypertension. And also there was significant increase in VEGF and SFAS in patients and other inflammatory markers in patients who had worsening of retinal pathology post-cataract surgery. See, we correlated these findings in the tear film also. So basically now we know that post-surgery, post-cataract surgery, sometimes there can be worsening of retinal pathologies, and there are certain biomarkers to help you to identify these scenarios before the surgery itself. So like I mentioned earlier, there was in patients with who had both diabetes and had hypertension had significantly higher levels of VEGF and MCP1. And there was higher levels of VEGF, MIG, L-sectin, and other inflammatory markers in patients who required some kind of retinal treatment post-cataract surgery. So this is our concept where we identify, isolate, and do customized treatment for these patients. So basically, we have developed this very unique, novel diagnostic kit, which is small, portable, and you can keep it in your clinic. And these have these cartridges or the chips, which depending on what biomarkers you are interested, we can customize those chips and give to you. So how do we use this kits in our clinic? Again, so let's say if your patient is undergoing cataract surgery, we collect the tears of these patients and then process it and put it in the cartridge. And once you put in the diagnostic kit, within 90 minutes, you will have the report in your hand, and you can easily identify which patients can worsen post-cataract surgery. So that way, it is so much more easier to explain to the patient or explain the prognosis to the patient, saying that, see, there is a very high chance of you your retinal condition to worsen after the cataract surgery, and also you can do some kind of a preventive measure. Let's say a preoperative itself, you can make the patient to undergo a strict control of systemic illness, and also you can plan some kind of intravenous injection depending on the retinal pathology. And then after a month, you reassess the patient and then go ahead with the cataract surgery. And these kind of patients, you can do, a close follow-up with the OCT and FFAs, watch for any kind of inflammatory sequel, and also stress on the fact that they have to continue, a very, very strict systemic control of the disease. So we have moved to a new dawn where we do customized treatment with the help of biomarkers, not just for the patient, in fact, for the eye itself. So what was known was specific biomarkers point towards certain retinal pathologies and can be used for screening tool for early diagnosis. What this study adds is a non-invasive diagnostic biomarkers, a point of care of diagnostic kit in cataract surgery to help predict prognosis and early diagnosis of retinal pathology, resulting in better cataract surgery outcomes. I thank you for your time.
Thank you, Naren. I think it is a unique concept. I just have one question for you. How many patients you would have tried in, must have already tried in some number of patients or sample size?
Oh, yes, ma'am. We have looked at it, ma'am, and we've been getting very consistent as of now. We're getting consistent result with the, one set of biomarkers when we identify before surgery itself with some retinal pathologies. Now what we're doing is we are concentrating on patients with already some amount of retinal pathology, and then we follow through. So what we do is pre-op, we take the tears again and then see. And these kind of inflammatory markers, when we see before surgery, we have found them, worsening post-surgery. So in this, we have at least found about 20 patients after we have identified these inflammatory markers, where 20 patients have progressed.
But if they have, say you do these inflammatory markers and then you say find that there's something wrong, then what do you do so that, they are eventually able to undergo the cataract surgery, because whatever retinal pathology that they have will continue to be there, whether it is PDR or whatever, so.
Absolutely, ma'am. So the whole point is, ma'am, what we are looking at is more of a strict systemic control, because see, usually what happens is there's all these intermediate markers. That means the system is not that great. There's a lot of inflammation going on in the body. So what we want to do is reduce this amount of inflammation by, controlling the systemic disease for a month, a strict control where we tell the patient, see, this is what you have. You need to really control it, look for 1 month. And if at all there's some amount of, let's say, moderate, or, it depends on what kind of a pathology. We can plan for an IV injection also, because sometimes what happens, retinal doctors, they say, okay, you finished your cataract surgery and then we'll give the injection, or sometimes they do combine. But in these kind of scenarios, actually what you can do is preoperative, give the injection, let it settle down, and then plan for the cataract surgery. Sometimes, a double, when you make the eye more quiet, or the inflammation, when you reduce, it gives much better outcome.
Sir,
Dr. Nan, is this kit available to the others? Is it available in the market now?
Yes, ma'am. Yes, sir. Actually, it is right now. We are actually, it's completely ready. But what we are trying to do is to manufacture in large scale and do the marketing. We don't want to get into it, so we're just about to finalize a partner. So they are going to do the marketing, and we will do the from the back end scientific and other.
Great. Wonderful one. Excellent.
Dr. Ravi Kumar Reddy, sir, would you want to
excellent
comment?
And one new era is going on. But crudely, whenever a patient of rheumatoid arthritis with cataract comes to me, I do 2 important tests called as ESR and CRP. What is the basis of this? When there is a high ESR and a high CRP, I don't touch that patient until that comes down. The same basis, the modern basis is by non-invasive and bedside. He has shown. Definitely, it is useful in the future.
Thank you, sir. Thank you.
Okay, thank you, Naren, for that wonderful talk.
Can I ask something from Dr. Naren?
Sure. Oh, you've joined, Rajesh. Welcome.
Yeah, actually, my internet is very unstable, and every time it breaks. And during his talk also, I lost connection. So I just wanted to ask one thing: is this kit meant to have the idea of the patients who are at risk to develop?
Sorry, sir, I couldn't hear the full question, but I think I understood the question, sir. So basically, what is the beauty about this kit is, so there is a diagnostic kit, and then you have different cartridges. So in the cartridge, you have the specific biomarkers which you are interested in. So let's say I'm a cataract surgeon. Now I'm looking at, post-cataract surgery, retinal pathology worsening conditions. If I'm looking at that, there are certain biomarkers which I showed you earlier. Then I can just say I want that, cartridge which has those biomarkers, so I can do the testing. So you can just test that. Or let's say if you're a cornea person, let's say you're looking at different inflammatory markers, or a refractive surgeon. Let's say if you're doing a lot of PRK surgeries and you want to predict which case can develop haze post cataract, post PRK. So there are specific biomarkers for that also. So we give different cartridges depending on the the surgeon, and also if you're interested in certain biomarkers, we give you those cartridges so that it'll be more. We just don't do customized treatment for the patient, also for the doctor. Also, we give customized cartridges so that it's more useful for you.
That's fantastic. Fantastic.
Dr. Naren, one question. Did you say the post PRK haze can be figured out through your biomarkers?
Yes, ma'am. Yes, ma'am. This I think we've also published in the Science Journal also, the same post PRK haze. We have identified very unique novel biomarkers with my mentor, Dr. Rohit Shetty. The NN team, we have identified very unique biomarkers with which you can actually, before surgery itself. See, we were all talking about intraoperative causes for PRK haze. That was a discussion in the past. We have been saying the lasers and so on and so forth. And Actually, what you can also identify is before surgery, even before you touch the eye, you can identify which patient will, probably have a higher risk of developing PRK case. And this we have also published now. Yes,
thank you, Naren. I think with this, we'll move to the last talk by Dr. Gopal Krishna, which is on posterior polar.
Is my video visible there, ma'am?
Yeah.
So today, my topic is posterior polar cataract, and with anticipated primary posterior capsular deficiency, the tips and tricks how to manage that. So this is purely a video-based session. So this is my first case. I have back-to-back 3 cases. This is the first case where I expected a primary posterior capsular deficiency PPCD. And routinely, we just do a clear corneal incision. In this case, the small paracensis appropriate to the needle, and then the capsular axis. The capsular, I make sure I always make a capsular axis around 5 millimeters, not a very big one, because I want to have a capsular rim so that in case if I have to place a sulcus-based IOL, this anti-graft will help me. The second step which I want to highlight is this hydro-free dissection, which I am trying to do with a flat iris depositor, sweep across the underneath the anterior capsule. And then if the cataract is soft, I can just do hydro delineation to see the golden ring, to make the nucleus proper, free from the cortex, so that while doing phacoemulsification, the primary posterior capsular deficiency, which is expected in this case, it will not enlarge beyond this. If you do a hydro dissection, obviously you will have a posterior blowout. And I prefer to do a phaco chop, because if I do a phaco chop, the stress on the journals is much, I believe, and I can do it in the central area. And because I already did a hydro delineation, I'm just doing a chopping. The central nucleus, the endonucleus is chopped, and then I try to rotate it and finish it off. And mind you, during the PPCD, whenever you expect a PPCD, I always make sure not much of a turbulence in the antechamber, because the turbulence in the antechamber will enhance the PPCD or will create the PPCD. So while coming out the main port, I always make sure I inject some amount of viscoelastic through the side port and stabilize the antechamber, and then only deepen the antechamber, then only my phaco port will come out of. In this case, I had a PCT there, I had a PPCD. If you see, the horizontal is there. Even now, I'm just trying to aspirate the cortex with the help of a automated irrigation aspiration, making sure that the low bottle height, low parameters, not much of a turbulence. And then I just try to aspirate as much of the cortex without much of a problem, because till now I didn't have any vitreous in the antechamber. We could do that. People prefer bimanual irrigation aspiration, which is very nice because it makes the antechamber much more stable. The fluid comes in from one paracensis and the aspiration happens from other paracensis, so that the antechamber is very deep. But I got used to use this coaxial irrigation aspiration for a long time, so I always try to do this. So whenever I just catch hold of this, make sure that you see now also I'm seeing there, while removing the irrigation aspiration cannula, I inject some amount of viscoelastic through the paracensis, never come out through the antechamber unless you have visco there inside. Stabilize the antechamber, deepen the antechamber, then only slowly come out with irrigation aspiration. Then that makes your PCD intact there without any enlargement. Then I try to inject some amount of viscoelastic there, because I don't have much of a vitreous loss here. I'm very sure about that. I enlarge a little bit here and I just place a 3-piece lens in this case. Most of the times, whenever I had a PPCD, I prefer to use a 3-piece lens, because I can place in the sulcus the 3-piece lens, as Dr. Srilakshmi is pointing out very nicely in her talk. The 3-piece lens stays in the sulcus so easily without causing much of a inflammation. And in this case, I thought because my rent is very clear and there is no vitreous much, so I thought I can place the lens in the back. So this is a primary PCD, and I had a PCD, and I could manage that without any loss of cortex and without loss of nucleus, and there is no vitreous. So these are the conditions, these are the conditions which compelled me or which forced me to place the lens in the back. There is no problem. I just rotated with the help of, I didn't rotate with a forceps, but instead I just use a simple McPherson's forceps to keep in the institute in the back, and then I just try to nudge the IOL to create a sort of optic capture there. And then because there is no vitreous, so I could just simply wash out, and I can always close the wound with a suture, or I can just, if the chamber is very deep, I can just leave it also because there is not much of vitreous. Suppose if I had a vitreous loss in this case and I had resorted to vitrectomy, then I would have closed. I should close this incision. I should make the antechamber tight and nice and tight. So this is the first case. So coming to this is a very good horizontal PCD. This is the second case where similarly I attempted to do a capsulorhexis, very nice capsulorhexis, and I always make sure that 4.8 to 5 millimeters so that I'll have an anterior capsular as I was telling you. And again, the same step, hydro-free dissection to keep the cortex. Mind you, these steps will help you, and this is hydrodelineation. And so if you see, you're able to see a golden ring there, and again, phaco chop, not much of rotation in the inside eye, and then just rotate it to my advantage, and the apex of the triangle into the phaco probe, and I finished it. See, at this case, I finished the only phacoing of the endonucleus, and I have a lot of epinucleus is there, and I have a, still I didn't have that. What I did in this case is I tried to visco-dissect the epinucleus. Some surgeons will not prefer this. They say even the visco itself will create the PCD. In this case, it happened so. I did see a PCD there. After injecting the viscoelastic, I tried to release the epic and epinucleus with the viscoelastic. And then I realized that I had a PCD. I know that the PCD is there. And then I am trying to aspirate the epinucleus with the help of my phaco probe itself under very low parameters, not much of turbulence in the antechamber, so that whatever the PCD occurred there, it will not enlarge, so that I can manage with a good intraocular lens implantation. So whenever you have a PCD, there is no need for you to panic. The only thing is you should have a good understanding of what is happening there. I'm trying to ease out the epinucleus, because if I have to use a bimanual irrigation aspiration, the epinucleus will take very long time, not much of turbulence. And then see, if you see the PCD is very obvious there. And now what I did is, I just didn't remove a phaco probe. I'm just taking a viscoelastic through the paracentesis and just try to inject the viscoelastic so that the PCD does not enlarge from what it is now. And then slowly the phaco probe comes out, and then this is, now I could see there is some amount of vitreous is coming. This is the place where I wanted to do a bimanual irrigation aspiration also, and then careful cortex aspiration. I'm making sure that the vitreous tracks are not coming into my mouth of the irrigation aspiration probe. Suppose if the vitreous is caught into the irrigation aspiration port, then there will be a lot of traction on the vitreous, which is not desirable. It may cause the peripheral retinal detachment sometimes, retinal breaks rather. So I'm just making sure, meticulously I'm just trying to do with a single rotation of my fingers, the probe, the port goes to the cortex, and I'm just trying, I'm mindful of the PCD there, I'm mindful of the vitreous there. So now I am coming out again, same step, same point I'm emphasizing again, visco through the paracentesis, make sure the AC is deep, then only remove the irrigation aspiration probe out. See, there is some amount of subincisional cortex still is there. Now I'm using this bimanual irrigation aspiration, and this helps better than the coaxial for the subincisional cortex. See, I'm making sure that I'm catching only the cortex, but still I know, I'm sure there is a vitreous is there, and I'm not pulling much of vitreous there. I'm just trying to peel out the residual subincisional cortex with a bimanual irrigation aspiration, gently, not much of turbulence in the antechamber, making sure that the PCD which is there, it's not extending beyond repair. See, still I'm seeing the PCD there. There is some vitreous is there. Because there is vitreous in the antechamber, I want to clear off the vitreous. So I used a triamcinolone acetonide tricot assisted vitrectomy. It shows me what all the vitreous fibers are there in the antechamber and the pupillary area. I'm just striking with a vitrectomy, and this is a irrigation cut aspiration mode. So because it's a vitreous I'm cutting. Suppose if I'm using for the cortex, I use IAC mode, irrigation aspiration, then cutting. And this is how, again, after vitrectomy, I'm making sure that I'm removing the other, the residual cortex subincisionally. If you see some amount of tricot into the vitreous also, there's no problem. If it's not too much, it's okay. But this case, as I have a vitreous loss, I'm not placing the IOL in the bag because I thought that not much of vitreous is there because I did a vitrectomy. So I'm placing this IOL in the sulcus, again the 3-piece with an injector with a 2.8 millimeter incision, and making sure that the leading haptic goes into the sulcus onto the capsule. And then again, after the IOL implantation, I am making sure the antechamber is free of vitreous, whatever the tax is. Because any vitreous in the antechamber, it is not desirable. It leads to chronic inflamed eye. It leads to CME, and sometimes it leads to the peripheral retinal breaks if the patient is a high myope or other things. So we want to clear off the anti-segment, and then we want to make sure the antechamber is very deep, the pupil nice and round at the end of the surgery. I'm just trying to remove what all the vitreous there in the antechamber, and then this case I just close it. The other case is the very high myope. So this case, the second case, I didn't lose the nucleus in the vitreous, but this case I lost the nucleus in the vitreous. I want to show how to manage that. So this again is a high myopic eye, and then I'm just trying to do as routinely rexis of around 5 millimeters. I want to make sure the anterior capsular rim should be there so that I can place a 3-piece IOL in the sulcus based on the anterior capsular rim. A nice and capsular rexis is done with the help of a capsular stain. And again, no hydro dissection here, only hydro delineation. I could see the ring there, not complete. And then phaco chop, impale the nucleus, and then central chop. I'm just doing that. Just go there. Yeah, it's a sharp chopper. Divide into 3 pieces. And this case, I lost the nucleus in this case. I'll show you why. Because this is already pre-existing posterior capsular dehiscence is there. Because it's a dense cataract, even the slit lamp also, I was not expecting it. But still, as a matter of fact, I did a hydro delineation. I didn't do the hydro dissection. Had I done a hydro dissection, I would have lost the nucleus just as I entered into the antechamber with the phaco probe. Because I did a hydro delineation, it gave me some time to eat at least some pieces of the nucleus. I'm just trying to eat out the second part of the second piece of the nucleus. And then I realized that the antechamber is deepening much. And then I'm just trying to eat away all the cortex or the other piece of the nucleus. And suddenly I realized that the PPCD is there. And then nucleus drop. One piece gone into the vitreous chamber. I realized that. That's the first thing you have to realize. You realize if you have a PCD, observe that, notice that. And if you happen to lose your nucleus to the vitreous also, no need to worry. Don't remove the handpiece. Stay there. Take a viscoelastic. Inject it through the paracentesis. Make sure the PC tear will not extend, and then slowly remove the phaco handpiece with a full anterior chamber so that it will be there. And then I try to do a irrigation aspiration because the nucleus, I know nucleus is dropped there. You don't need to panic, and you don't need to, most important thing is don't need to change the nucleus. It is gone into the vitreous, no problem. The vitreal surgeons will manage very well. There is no issue about that. And try to remove the cortex, whatever it is. And I want to place an IOL before handing it over to the posterior vitrectomy surgeons. Because if I place an IOL and give them the vitrectomy surgeons, and their job is half done. Because if I leave them FA kick and they have to go for either a scale fixated IOL or they can have to go for iris claw lens. So I want to save their time. If the anterior capsular rim is very good, that is the reason why I always make sure that I will do only around 5 millimeters or less than that, so that I can place the IOL basing on the anterior capsular rim. I'm just trying to remove the cortex and coaxial without much of disturbance. And then I just keep on injecting into the viscoelastic. Not much of vitreous into the antechamber till now. I'm just checking manually with the help of a iris repositor to see whether the vitreous tags are there. In this case, I prefer not to do vitrectomy myself here because anyway, I'm going to hand this case to my vitreoretinal fellow friend. He will manage the vitrectomy also. He will manage the vitreous in the antechamber also from the pars plana vitrectomy. So I'm making sure I'm not worried about the small pieces there retaining in the antechamber also. And then I'm just making sure the lens is well into the sulcus. And then the 3-piece IOL in the sulcus. I'm not worried about some amount of cortex left over there. I'm not worried about the small fragments there because I want to place the lens in the sulcus, make sure it's very well, and then secure the wound. That is the very important thing. And in this case, I have to secure the wound, and then I refer this case to my vitreoretinal surgeon immediately, and then in the next room. And he did this TPPV parsoplantar vitrectomy, and it's very safe because he does the vitrectomy from behind and not much of a traction on the retina. So he did this job very cleanly, and then as already lens implanted is there and his job is half done, he removed the nucleus for me, and then we just finished the surgery. The patient was seeing 20/30 in no time. So the point which I want to highlight is whenever you have a PPCD, posterior parallel cataracts, always assume there is a PPCD and you prepare for the nucleus drop. That's the best thing. If you are prepared for that, then there's no problem. The first tip is no hydrodissection at all, only hydrodelineation. And viscodissection of cortex is the debatable point. You can do or you cannot do. And you remove the instrument while inflating the anterior chamber or viscoelastic so that the PPCD will not enlarge. And these are the 3 tips. And again, whenever you have a nucleus drop, don't chase the nucleus fragment. If you try to chase the nucleus fragment, you are damaging more to the retina by removing the vitreous from the anterior side. So parsoplantar vitrectomy is always better, and you have a vitreoretinal surgeon, you just leave it to him, they will be able to do that. Even if you take 1 or 2 weeks also doesn't matter. Sometimes the VR surgeons may like to settle down the anti-segment inflammation, the corneal edema to clear off, they want to wait another 1 week, there's no issue. So prepare, plan, execute, and this is how the PPE will work out for the PPCD. So that is the case, the third post-operative day, the patient was seeing 20/30 without any problem. And that's how we can manage these primary posterior capsular deficiencies efficiently and give the patient the best vision. Thank you for attention, sir.
Thank you so much, Dr.
I think
Gopalakrishnan.
one thing very important is whenever there is a posterior capsular rent, I prefer to do cortical aspiration by using the vitrectomy cutter itself. Because once you catch the vitreous into your irrigation aspiration port, it is very, very difficult to disengage it now.
Yes, sir.
So use the vitrectomy cutter instead of, and use it in a IA mode. And if you catch the vitreous, you immediately go into vitrectomy mode and cut it over there. So that way you don't have to worry about. Secondly, vitreous has got a tendency to come towards the incision. So that means the area from PCT and away from the incision, actually there will be no vitreous most of the time. So like in the case where you were trying to confirm whether the vitreous is in the wound or not. So you go from the virgin area, make another incision, come close to the limbus into the AC and try to sweep the vitreous in. So if there's any vitreous tract which is coming towards the incision, you will feel it and you will see it, and you will see that it is coming in. And of course, all anterior segment surgeon has to be mentally prepared to do the pars plana vitrectomy. I mean, whenever you do from the anterior root, then some amount of, I have never found even a single patient in my life when we do anterior vitrectomy and the vitreous is not in the AC. So in those cases, then I put the IUL and constrict the pupil before putting the tricot so that it does not go inside the vitreous cavity, and dilute the tricot to 1:4 because we just want very little bit of identification of the vitreous fibers. We really don't want such a big blob of white tricot inside. And in the last myopic case, I really do not, I'm not convinced that doing a hydrodissection, not doing a hydrodissection was a good idea. Because whenever you try to, either you left the nucleus and prolapse the nucleus into the anterior chamber and then do it. And if you're trying to rotate the nucleus by just doing hydrodelineation, then the epinuclear plate is stuck with the nucleus. And inadvertently, because this is a high myope and the posterior capsule was thin, in fact, that may have contributed because no phacoprobe came in touch with the posterior capsule. So that might have been responsible for creating a PCR. So in a high myope, unless you are like in a posterior polar, without rotation, you lift up the nucleus, prolapse the nucleus, it's fine. But if you are trying to rotate it, then I think it's better to do the hydrodissection in these patients.
I think well said points. Dr. Ravi Kumar Reddy, sir, would you want to add something? I think very challenging cases were shown with the open posterior capsule and all scenarios. in the bag lens, out of the bag lens, and then a nucleus drop also, and then still yet managed by a VR surgeon. So Dr. Ravi Kumar Reddy, sir, would you want to say something?
Yeah, nice videos. What we do in our institute is no hydrodissection, no hydrodelineation for posterior polar cataracts. No hydro procedures. Directly we attack the nucleus. If the surgeon finds difficulty in managing, we do two procedures. One is from the trench, we inject the fluid, it will clearly give the hydrodelineation. That is rarely we do. The other thing is we do visco delineation of the epinucleus where it comes as a block. The other thing is whenever there is a deficiency and no vitreous loss, we do put a single piece lens in the bag. When we put a 3-piece lens, always we capture and push the lens behind the rexus. Because post-operatively also the lens comes forwards, vitreous prolapse will be there into the anterior chamber and the pressure differences will be there. It is a must to tuck the.
We've lost the Dr. Gopal Raju. Would you want to say something?
So nowadays with the SSO OCT base like the IOL Master 700, we can fairly anticipate the intactness of the PC and then the risk of the PCR. That was one additional tool we have nowadays. And the second thing is, like Banslar said, I think we need to learn do vitrectomy from the posterior segment side. We need to enter into that territory, and then that will be all.
Yeah, that is not a difficult thing. If you watch the vitreoretinal surgeon for 1 day or 2 days, you
can learn
it.
Like in initial days of mental
suture lens with the trocar and cannula, you can push it.
Yes,
and the only thing is you need a high-end cutter and a high-end vitrectomy machine where the speed is more than 2000.
Yes, sir.
So I think we've had great discussions and very nice talks on varying subjects, again, very complex situations. So we would like to thank all the speakers, all the delegates who joined us. We had a huge viewership on YouTube especially. And we would also like to thank our audiovisual team, our AIOS headquarter team headed by Mr. Kripal Rana. And of course, Alargan for getting us all together on board and for sponsoring this event. Thank you very much and hope to see you again. Thank you.
Thank you, madam.
Thank you, madam.
Bye-bye, everybody.
Bye, sir.
Thank you, ma'am. Thank you, everyone.